Okay, it's 12:02, so as promised, we will just go ahead and get started, and any stragglers will just have to jump in as they go. Thank you all for joining us today. We will be diligent in sticking to our hour-long time frame here, so we are hoping to have a lot of, as you know, this is our Direct Contracting 101 briefing. The plan for today is to do a brief overview of the direct contracting model. There are several different tracks and components and various options that are on different paths. And so we will just sort of level set with an overview of what the model is and specifically how the global and professional model option fits in. I will then turn it over to our esteemed group of panelists to introduce themselves and their organizations. We are pleased to have a great lineup representing a variety of different perspectives here. So they will tell you a little bit about their particular interest in the direct contracting model and what their organizations are focusing on. With the remaining time, we will do a moderated Q&A. And then again, always, of course, throughout the entire briefing, you're welcome to use the Q&A function to submit any questions, and we will monitor that throughout, throughout the hour, and then answer as many of them as we can at the end. So as mentioned, I didn't introduce myself, but Kristen McGovern with Sirona Strategies. I will be serving as the moderator and we'll sort of kick things off here with, as I mentioned, we're just going to start by leveling because there are so many actions. There are two you can see here on the slide. There is a global and professional model, which is currently underway and being tested within a first cohort. And then there was also separately regarding the geographic direct contracting model, which was an entirely separate model that was to be tested through a different, through a different model program. As you can see here on the slide, the geographic direct contracting model is currently under review and is no longer planning to start on January 1st, 2022. So what we will be focusing on today is really the global and professional direct contracting model that is, as I mentioned, underway with the first cohort that started in April. So what are the model goals? And this is taken right from the CMMI website. We will talk a little bit more about how this model, what this model aims to test, how that is different or the same as things that have been tested in the past. But you can see here three broad-based goals. So transforming risk-sharing arrangements and Medicare fee-for-service. So this is really important just to sort of orient yourself as to which part of the Medicare program we are talking about here. So this model, the global and professional model, which is the focus of today's discussion, is being tested in fee-for-service. It is not being tested in Medicare Advantage, which is where you would traditionally find the private health plans offering a Medicare option. So in this case, the payer is CMS itself as the fee-for-service payer. A second goal of the program is to empower beneficiaries to personally engage in their own care delivery, and we will talk a little bit more. You're fortunate enough to have Families USA and Community Catalyst here who dedicate all of their time to thinking about these things from the consumer or the perspective, a little bit more about how aspects of the global and professional model do empower beneficiaries or are expected to empower beneficiaries throughout the course of the model. And then finally, reducing provider burden to meet healthcare needs effectively. We will again talk about various aspects of the model that enable providers to more efficiently or aim to enable providers to more efficiently and effectively care for their patients. And a big component of that is the payment model that is associated with this model. So as I mentioned, one of the things that it may have been particularly confusing about the direct contracting model for those of you who are trying to sort of untangle what we're talking about and what's being tested, One of the things that is, I'd say, both the blessing and a curse of the model is that there are a range of different types and options for DCEs, direct contracting entities, to choose, sort of based on their care model and serve. So right now, there are 3 different types of direct contracting entities, and you can see them here. There was a 4th type of direct contracting entity that was previously announced by CMMI. That's the Medicaid Managed Care Organization, DCE, and CMS has announced that they are no longer planning to solicit applications for this type of DCE. So that was a type that was specifically targeting health plans and payers who maybe eligible population. And if they're managing the Medicaid spend, the idea was that they could also manage the Medicare spend. But CMS has decided not to solicit applications for that type of DCE at this time. So the 3 types of DCEs, direct contracting entities, that are out there today being tested and include the standard DCE, which would be your traditional Medicare fee-for-service provider that has experience in the Medicare fee-for-service market. A new entrant DCE, which would be an organization that has a provider organization that has not traditionally provided services to the Medicare fee-for-service population, but has maybe served another population like a Medicare Advantage population or a Medicaid population. And they believe that their care model could be effectively used to provide the same types of benefits and services to the fee-for-service population. So they're sort of switching from one market to another market, or expanding from one market to another market. And then the last type of DCE is the high needs population DCE. So these are DCEs that serve Medicare fee-for-service beneficiaries with complex needs. So this is a population that meets certain clinical criteria as far as having complex and potentially chronic care conditions. So each DCE picks which type of entity they are going to be, or is assigned which type of entity they're going to be based on their past history. Then they are able to select a payment mechanism. So the 2 payment mechanisms are primary care capitation and global capitation. Under primary care capitation, the entity is taking risk for primary care services only. Under global capitation, the entity is taking risk for the total cost of care. So that includes care that is maybe being provided by others outside their entity, and it really represents the total cost of care. There are also, and we can go into more detail on this of efficiency. I'm doing this at a fairly high level, and then more will be fleshed out in the conversation. So once you've selected your DCE type, once you've selected your payment type, there are also several options for how you get patients or how patients are aligned with your entity. One mechanism is claims-based alignment. This is something that is widely used in other ACO and shared savings programs being tested throughout the department. The idea here is that CMS does a look where the patient, if the patient has traditionally been receiving care from a provider associated with the entity, then they would be assigned based on claims and based on their past, utilization to a particular DCE. A second mechanism, which has also been used in other programs, but is really being used more in this particular model, is voluntary alignment. So this is where the beneficiary communicates their desire to be aligned with a direct contracting participant provider. So if Dr. Smith comes to me and says, hey, I'm participating in this program, do you want to receive care through this program from me as your provider, then the patient could say yes, or the patient could say no. If they say yes, then they would be aligned to that direct contracting entity that provider works with. So what is the current status of the program? And this is the last slide, and then we'll turn it over to our panelists to introduce themselves. So as I mentioned, a geographic model was totally separate and has been put on hold for now. So the current status of the program that we're referring to here is really the global and professional direct contracting model. And it launched with a first cohort of 53 participants in April 2021. You can see here the various DCE types. Overwhelmingly, most of the participants in the first cohort are standard DCEs, which means that they have experience working with the traditional care fee-for-service population in the past. There are several, as you can see here, new entrants, which means that, again, that they're switching. They don't have that historical fee-for-service experience, but they have provided care to other types of patients. And then you've got the high needs population, DCE, which really focuses on that complex chronic condition. CMMI also plans to launch a second cohort on January 1st, 2022. This will be organizations who maybe applied for the April start date, but didn't end up starting in April for one reason or another, and all the next generation CEOs who may be choosing to go into direct contracting when their program ends at the end of the year. So that's sort of the level set here on what we are and what we are not talking about when we're talking about the direct contracting model that's currently being tested today. With that background in mind, I'm going to go ahead and turn it over to the panelists to sort of introduce themselves and their perspectives on the model, and why are they here speaking today about this model. And we will start with Gary Backer, who's Executive Director of Advanced Illness Partners.
Hi, thank you so much, Kristen. It's a pleasure to have a chance to be with everybody today. As Kristen mentioned, I serve as Executive Director for a direct contracting entity known as Advanced Illness Partners. I'll talk about these organizations in a moment. I also at Capital Caring Health, which is one of the participants in AIP, serve as the Chief Officer for Strategy, Policy, and Legal Affairs, and I'm also an advisor to CTAC, the Coalition of Transform Advanced Care. Previously, I served as the Chief Strategy Officer, non-politically appointed at the Innovation Center, and was there at the time that the direct contracting model was originally being developed. So again, pleasure to be with everybody today. In terms of AIP, as hopefully you can see on the slide, we are made up of 7 community-based nonprofit provider organizations, all of which provide a full continuum of care from the time that somebody develops complex chronic conditions or advanced illness all the way through end of life. All of our organizations provide primary care services, palliative care services, in-home supports, as well as hospice services. And the interest among AIP partners in participating in this model is really to be able to do that on a sustainable basis. And so to be able to provide the continuum of care for people with advanced illness in a seamless way, which is not easily done under the current fee-for-service system, which I'm sure we'll talk a little bit about. So that's the main interest in Advanced Illness Partners and the interest in direct contracting. Again, pleasure to be with you today.
Great, thanks, Gary. I think we will turn next. Let me see if I can get these slides to advance. This is more background on Capital Caring Health, which Gary mentioned he is also associated with as one of the participants in AIP. Next will be Emily Stewart, Executive Director of Community Catalyst.
Hi, thanks for having me. And yes, thank you for that slide. So I just wanted to start by sharing that Community Catalyst is a national advocacy organization that was started with really one important premise, which is to make sure that people are fully engaged in the decisions that impact their health. And this is especially important for people who face unjust barriers to coverage and care, people of color, immigrants, people with disabilities, and older adults. We as an organization have always embraced that one of our biggest roles is making sure that highly technical yet highly impactful decision-making processes involve the very people that they are about. And that's actually why we created the Center for Consumer Engagement and Health Innovation, which is a program that is focused on ensuring that people are represented as beneficiaries, as consumers, wherever new payment and delivery models are introduced at either the state or federal level. One of the things that I want to do today, just at the outset of the conversation, is to share some research findings that we recently conducted, which, while not directly about the direct contracting models, I think have some important insights nonetheless. We conducted some research on dually eligible individuals and their experience with enrollment into integrated care products, with a focus on Medicare and Medicaid plans offered through the ACA's financial alignment initiatives. And this is relevant to this discussion for two reasons. Number one, I think that research exposes some underlying issues that are relevant to this discussion. And also, dually eligible people face some of the greatest barriers to quality information and care. And so they are a group that has a lot at stake, I think, with respect to the models being discussed today. And you can take it to the next slide. So I should mention that this research was funded through the generous support of Arnold Ventures and the SCAN Foundation, and just want to highlight a few key takeaways. The first is that I think actually we want to go on the slide before this one. Yes, thank you. The first is that provider access continues to be very important to dually eligible people. So one finding is that the limited networks of the Medicare and Medicaid plans really hindered access for a lot of people, a lot of important providers to them. That was particularly true for people with chronic or complex health needs. We heard from beneficiaries about the struggle they had with moving to an integrated care plan and having limited access to Medicare providers because they were going from original Medicare, where they could see any provider, to a managed care plan, and were concerned with the inability to see providers who they had a relationship with. So it's important to note that under the direct contracting global and professional model, beneficiaries are not restricted in terms of where they can go from care. They can get care from any Medicare fee-for-service provider that's not associated with the DCE, and that's different from some of these integrated care plans. So in this way, these models do address a key concern for dually eligible people that they have with the Medicare Medicaid plan. So it's possible in some respects they could represent a better option for this population. However, having a right doesn't mean that people understand it. And certainly, as the case with the integrated health plans, people had the ability to opt out, but often did not understand that right there too. And so resourcing information for enrollees about their rights, in particular the ones they care most about, like provider access, is going to be key. The second finding is around passive enrollment, that there are challenges with that. So that's the process of automatically enrolling people and then trying to give them information about how they can find their way out. And that prevented, as I was mentioning, people from making this process has prevented people from making informed decisions about what these plans are, how they can benefit them. Interestingly, some of the things that people really liked, ultimately decided that they liked about integrated care plans, was around some of the additional benefits, which could also be provided here, but that wasn't always clear to them. Specifically, the passive enrollment notices were insufficient. And also the method by which that they were delivered didn't really work. A lot of times people were just getting direct mail, and that has proven with our research to not be the most effective or preferred way to communicate with dually eligible people. The bottom line is that they communicated very loud and clear that they're looking for knowledgeable, trustworthy experts they can speak to about what these models mean, what it could mean, beneficially for their care, what they might be giving up. And the infrastructure challenge here is that this is a problem across the health sector, that there's not enough resources to fund trusted community-based organizations who are really well positioned with training and financial assistance to do exactly that. And you can take it to the next slide. So in applying these findings, there's really just three overarching themes. The first is that the global professional models could improve choice and access to care for some Medicare enrollees. We think that could be a benefit for dually eligible individuals who are looking for better care today. So that's something to highlight. The second being that there really do need to be deliberate and resource efforts to conduct outreach and education work, make sure people have good information about what the models are, how they might help them, and critically, really ensuring that people understand their rights, particularly with respect to all the rights that they still will be afforded to them under this model. And finally, evaluation is key, and making sure that people are at the center of that evaluation is essential, that we are monitoring and understanding experiences and making important adjustments. So, obviously this is very early, so I don't think that there's a lot of bottom lining that could be done from the perspective of how beneficiaries are experiencing this, but we certainly appreciate conversations like this. And on the evaluation front, just think it's essential that consumer and community voice is front and center. Thank you.
Great, thank you, Emily. Next, again, if I can get the slides to advance. Next is Sophia Tripoli, Director of Healthcare Innovation at Families USA.
Hi, everyone. Thank you so much to Kristen and to the panelists and for everyone for joining today and for having us on. I'm Sophia Tripoli. I'm the Director of Healthcare Innovation at Families USA. Families USA is a nonpartisan consumer healthcare organization working to ensure that every living person across the country has access to affordable, equitable, high-quality healthcare and the good health that they deserve. We work at the national, state, and local level across 4 key areas, which you can see on the slide: health equity, healthcare value, healthcare coverage, and the consumer experience. Broadly speaking, our interest in new payment and delivery models is really grounded in the idea that healthcare costs continue to rise without commensurate improvements in the quality of care or improvements in people's health. And there are several drivers, of course, of unaffordable healthcare and poor health in our country, but including the role of how we organize, deliver, and pay for healthcare services, which is largely based on a payment that reimburses healthcare providers for individual units of care rather than meeting the complex and diverse health needs of their patient population. This predominant payment model, as you know, fee-for-service, results in fragmented care delivery, incentivizes higher volumes of procedures and tests, doesn't pay for critical services like addressing the social determinants of health or reducing health disparities, which we know drive the majority of people's health. And really importantly, fee-for-service has no link to the quality of care provided or to improved health outcomes. So this type of payment model and care delivery system impacts the affordability and quality of care for every person across the country, but it has even worse impacts on our nation's most vulnerable families and children, including the potential for widening existing disparities in health and health outcomes. So we really believe at Families that to lower healthcare costs and improve people's health, we need to create new financial incentives in our payment systems that will drive better value for consumers and for other purchasers of healthcare. And specifically, we see driving towards alternative payment models that are built on ongoing capitated payments as critical financial incentives that enable providers to meet the full health needs of their patient population, including reducing disparities and addressing the social determinants of health. So the direct contracting global and professional model, and Kristen, you can pop to the next slide, is really a promising, we see as a promising payment and delivery model that's working to bring new financial incentives to the Medicare fee-for-service population in an attempt to lower healthcare costs and improve the health of some of those of the most vulnerable people in our country. We're particularly excited about the track of this model that's really designed for high needs populations. So those with the most complex healthcare needs that are often falling through the cracks of the healthcare system. And we are really interested to see how the new financial incentives that Kristen laid out in the introductory slides and comments with higher risk arrangements perform in this model, particularly around the primary care capitation and the global capitation model. And then I think the last thing I'll say is just really endorse everything that Emily just laid out from the consumer perspective. I think, we really want to keep a close eye, as we do on all model rollouts, on this model performance, to make sure that beneficiaries are getting exactly what they need from the healthcare system, and that there are no impacts hindering their access to care, accessing quality care, that they're not experiencing any adverse experiences or outcomes, and that, to the point about evaluation, that we're really making sure that we're creating sort of real-time feedback loops in these types of models that allow patients to be providing ongoing feedback about their experience in these models, to make sure that we're able to understand the impacts that they're having on an ongoing and real-time basis. So I think the rest of it we'll get into in the discussion, but thank you very much.
Great, thank you. And last but not least, we have Akash Shah, who's the General Manager at Cityblock Health.
Thanks, Kristen. Hi, folks. I'm Akash. I'm the General Manager at Cityblock. I come to City Block by way of the regulatory side. I was at CMS designing and launching several value-based care programs from the private payer side and the provider side. At City Block, we are a provider organization focused on the underserved communities through rebuilding trust, eliminating inequities, and improving health outcomes for our members. The population we serve, about more than 70,000 members across 6 states. Almost half of these folks are Medicaid beneficiaries. About a third are Medicare beneficiaries, primarily MA and duals. 2/3 of them have low social supports, and 16% of them struggle with unstable or unsafe housing, with similar statistics for food security and access to transportation. These are also medically complex members with at least 4 chronic conditions on average. Our approach to serving these members is to focus on their physical health, behavioral health, as well as their social needs in an integrated manner with integrated care teams. We employ community health workers, we employ physicians and NPs, as well as behavioral health specialists, all working together to develop and follow members through care plans. From a business model perspective, we take on 2-sided total cost of care risk. That means that if we can improve health and reduce unavoidable expenditures, we can share in savings. If we are above that target, we will pay back. We take that both, high risk, high reward approach, and we are built on capitation. We're not a traditional provider who's transitioning necessarily from fee-for-service to capitation, but we have been purpose built to operate in the capitated world with economic incentives focused on outcomes and health. Next slide, please. In terms of we are excited to participate in direct contracting. We planned to start in January 2022 in the professional track as a new entrant. 3 particular pieces that really excite us for direct contracting are: 1, this is a way we see for us to expand our care model to serve underserved Medicare fee-for-service and dually eligible beneficiaries. We do serve Medicare beneficiaries today, but mostly in the MA space. So we're looking to expand into the fee-for-service population. Number 2, as we kind of expand into this new cohort of members to deliver our services, direct contracting offers us an opportunity to more timely attribute these members to us through the voluntary alignment and quarterly alignment options. And then lastly, the capitation piece is really important to us. Again, we are not a fee-for-service provider. We don't have existing fee-for-service revenues that we're trying to bolt onto, but rather the capitation payments we see as a really helpful way to provide us with sufficient funds to allow us to deliver the care management activities we want to deliver, focusing on social, behavioral health, and physical health needs of our members. And that's it for me.
Yep, great. Thank you to all of our panelists. I think right now, so I stopped the screen share. We're going to transition to our Q&A section. And so I think hopefully the information that we've provided so far is a good level set as far as various options under the model, and then the various perspectives that we have represented here on the panel today. Just to recap, so Families USA and Community Catalyst really are bringing the beneficiary perspective today. Gary's organization, Capital Caring, is participating in Advanced Illness Partners, which is a high needs direct contracting entity that started the program in April 2021. And then Akash represents City Block, which will be a new entrant planning to start the program in January 2022. So we have a range of different perspectives. People are at a variety of different places as far as the implementation of the program. And we are hopeful that that perspective will really come together to provide a really robust discussion during this Q&A. So we've already talked about this a little bit, but I think, Gary, I'll start with you to just sort of, again, ground us in what the direct contracting global and professional model is, how it works, why CMMI is sting it. So again, if we could just go over some of that information from your perspective.
Great, thanks, Kristen. I think my co-panelists did a wonderful job in some ways kind of fleshing out the answer to that, but just to kind of recap on a couple of things, if I took it up a level and thought about what is direct contracting, really it's a primary care-based, longitudinal, accountability-based total cost of care and quality model. And it focuses on innovation, but at the same time, it builds on existing models like NGACO, and even in some ways, other models like independence at home. And what all that language means in terms of primary care-based, longitudinal, accountable, et cetera, it means that it focuses on primary care for attribution, whether that's based on claims and experience or as was explained on voluntary alignment. It seeks to provide what are known as capitation payments. So those are more bundle type payments that are provided on essentially a PMPM basis. And the reason for that is to help the model move away from fee-for-service, which is challenging for primary care. Fee-for-service doesn't really support a team-based approach to primary care, which this model is trying to encourage. Longitudinal means it follows patients over time, and accountability means that it holds the direct contracting entities, so in our case, advanced illness partners, accountable for total cost of care, and specifically in this model, parts A and B of Medicare, accountable for both total cost of care and quality. And as I mentioned, while it's innovative in many respects, it also builds on existing models like NGACO. I think in terms of why put this model into place, what are some of the kinds of things that are being tested that are innovative? Again, my co-panelists have really hit these, but one, it's really the movement away from what's known as kind of the fee-for-service chassis. A lot of that is achieved through either the primary care capitation or what's known as the total cost of total care capitation, providing access to a number of different kinds of organizations that previously couldn't participate in a value-based model. And so trying to kind of encourage broad transformation and placing emphasis in particular, as you referenced, our high needs organization on high needs medically underserved individuals. And the reason for that and what some of the challenges in the past have been is that it comes from an observation that many provider organizations that serve people with significant medical, clinical, social, behavioral needs, very often those kinds of providers are smaller in nature. They're community-based, like our participants in AIP. They can't on their own very often meet kind of the standard attribution requirements. So the standard attribution requirement in this model is, for instance, 5,000. Even for new entrants, it's 1,000. It's 250 aligned enrollees for the first year of the program for high needs DCEs. The idea is to recognize that and give those community-based organizations in particular an opportunity to participate in the value-based model. And it also recognizes that if you're exclusively focused on high needs individuals, so again, those that are have complex medical needs, have advanced illness, it's also important that we think about risk adjustment a little bit differently, which is one of the innovations that comes from this model. And that's because if you're taking care of only a very sick population, they're decompensating, they're deteriorating rather rapidly. In the traditional way that risk adjustment is conducted, you look back to the previous calendar year, that's known as prospective risk adjustment. But the problem is the patient's level of illness burden is changing so quickly that looking back to the past calendar year for what the patient looks like isn't very indicative of the present. And normally in risk adjustment, if you have a mix of patients, that's okay, it balances out. But if you're only taking care of those that have high needs, there's no balancing and you have to think about risk adjustment a little bit differently. So both thematically, the focus on high needs, medically underserved, but then also thinking about what does that mean? How do you actually put that into practice and testing and innovation, even as we think about risk adjustment? So those are the things I think that I would use to characterize the model and some of the innovations that I would point out.
Great, thanks. So if I'm a beneficiary, how should I be thinking about this model, and how does the global and professional model, or how is it expected to impact beneficiary choice and flexibility? And I think we had maybe Akash respond to this, but also Sophia and or Emily, just sort of thinking about how the model innovates around the beneficiary experience with respect to choice and flexibility.
I'll start with this one, Kristen, then turn it to Sophia and Emily. From a beneficiary choice perspective, there is no change to their freedom and access to the full Medicare network of providers in the country. Unlike Medicare Advantage, there is no narrowing of the network, there are no prior auths, there is no gatekeeper model. So members retain the same freedom and flexibilities they have before. And as Emily and Sophia have highlighted before, do they know about these freedoms and flexibilities? Based on the two different ways that a beneficiary can be attributed to a direct contracting provider, one is claims-based, basically, who have they been seeing before? And if they've been seeing Dr. Chen for the past 2 years, past 3 years, they'll continue to see Dr. Chen. There's no change there. And it's more now Dr. Chen is incentivized more appropriately on the value-based kind of approach as a fee for service. For voluntary aligned beneficiaries, they are actively choosing, not passive, but actively choosing to participate in the program. CMS has provided pretty strict guidelines on how those conversations can happen and in which settings can they happen to reduce risk and kind of pressure on beneficiaries and on members. But within a very narrow set of guidelines and settings, beneficiaries can be asked whether they want to participate, have an opportunity to have any questions they have answered, and are given standard forms set by CMS that dictate, that clearly highlight that they retain choice, that they can switch, that this doesn't change their benefits. So from an overall benefits perspective, there's no change to beneficiary choice. For those who are claims-based aligned, they'll be aligned to the docs that they've already been seeing and know and trust. And for those who choose to voluntary align, that'll be an active choice to say, I would like my care coordinated by this direct contracting provider.
So I'll just
Great.
add on.
Sophia or Emily.
Sure. Sorry, Kristen. I'll just add on to everything Akash said and just say, I think, one of the things that's being tested here is sort of some enhanced flexibilities, some enhanced benefit services to beneficiaries through this model. So the benefits include existing benefits that are already provided through the existing next generation accountable care organization model. So things like some expanded telehealth services, some post-discharge home visits, some care management home visits, chronic disease management services, and incentives for beneficiaries. And then Global and Professional is adding on some additional services that beneficiaries will have access to, including some new home health services provided by a nurse practitioner and some loosening of some of the regulatory controls over a nurse practitioner being able to visit and do at-home visits for beneficiaries. Some new flexibilities around homebound care requirements that basically allow patients to more easily return home or stay in their home to receive care. And then flexibilities around hospice care that allow beneficiaries to receive more palliative care services in hospice that we know have been proven to enable better pain and symptom management for beneficiaries, improves care coordination for them, and also has been shown to increase shared decision-making with patients based on their care plan that's been developed for them. So there are some additional enhanced benefits that are being offered through the model that I think are really important opportunities just to point out for beneficiaries who are going to end up receiving care through the global professional tracks.
I would just add, I think that just to add on that last point, in our research, it's shown that that's information that people are really interested in learning more about, those added benefits. I would also say that there's a lot of innovation happening in the Medicare space. And, one of the challenges on the ground is people deciphering what is happening where, because they're getting a lot of notices from different plans under different programs, and it is extremely confusing. And particularly for a population that is often the target of fraud. For a lot of people, when they get these different notices and different phone calls, it feels like they're being the victims of fraud. So we hear a lot of that in our focus groups and research. People saying, "I thought that was a trick. I didn't realize that was real." So I think it is both true that there is this opportunity for people to have better access to primary care, particularly for people with complex needs, to feel better about and enjoy better benefits. And it's also true that it's extremely difficult given the way the system is set up today and the lack of infrastructure to help people navigate all of that, for people to truly understand what their options are to make these choices with respect to their healthcare providers and choices with respect to which programs they want to stay a part of. And so I would just reinforce that comment about making sure that we're acknowledging how this all plays out on the ground for somebody who's just a beneficiary, getting a lot of information and not really any support in terms of figuring out what to do with that.
And I think, Emily, to your point before, just about for the providers, the DCEs, and for CMS to be thinking about ongoing ways to engage consumers who are getting care through these models, to make sure they understand, what does this really look like on the ground? What's the information that they're getting? Obviously, CMS has requirements that are put into place, but sometimes it doesn't roll out exactly how we anticipated or hope it will. So making sure we're building that feedback with the patient population to understand what the impact is on them, how it's going, I think is really critical as well.
Agreed. And I think in particular, in thinking of an emphasis on health equity and looking at how that experience is felt, based on race, based on gender identity, et cetera, is really important.
That is a great lead in. I think the next thing I wanted to ask about, now that we have sort of addressed some of the issues, and considerations with respect to choice and flexibility, one of the things I wanted to ask about is the potential for this model to target underserved. So when we are thinking about a health equity lens and underserved populations, what are we hoping or expecting that this model will achieve? And is there an opportunity for the global and professional model to further expand access to primary care and some of those other kinds of services, just in light of the fact that the payment model, being a capitated model, as I think maybe Akash and Gary mentioned, does provide the direct contracting entities the flexibility to have more of a high touch model that, wider array of phone calls and emails and telehealth visits and those kinds of things than would otherwise be allowed in the fee-for-service program. So I guess what kind of flexibility when it comes to access to services, and how are you thinking about reaching underserved populations? And Sophie and Emily, any flags when it comes to health equity or disparities that you want to raise? Gary or Akash, do you want to start with how you're thinking about access to primary care and
Sure.
underserved populations with respect to your core service areas?
Sure. I'll start off just by talking a little about some of our providers. I think High Needs is a very important vehicle to try to help reach medically underserved populations. It's not the only vehicle in direct contracting, but as you mentioned, I think one of the keys really is the payment model approach does allow for a blending of the medical, the social, and the behavioral health related services, which I think is really key to providing good comprehensive integrated care. The High Needs option within the model, takes some inspiration from the PACE program, which serves principally dually eligible people. And many of our beneficiaries that we're providing services to actually live in different forms of congregate homes. And so that includes adult foster homes and lower income congregate home settings. And it's really the model that's enabling those services to occur on a more flexible basis, and really focusing on what the family, what the person and the family need in terms of the kinds of services that are being delivered, and then being able to take advantage of some of the flexibilities that were outlined previously to kind of provide those types of care. And again, the reason why that's challenging under fee-for-service is, as you pointed out, fee-for-service really pays for visits and procedures. It doesn't allow for, as some of my colleagues say, kind of the interstitial spaces to have many more touches occurring with the patient population, and really not just focusing on the pure clinical, but really beginning to unpackage the socially determined services and, again, behavioral health needs. So a lot of our experiences, the model does help us reach medically underserved populations. I think, ground zero for us in some ways is really as we're working with people in settings where you would typically find lower income populations and medically underserved populations. And I think we're having some success there. Again, all made up of community-based not-for-profit organizations.
Gary,
Kosh?
from City Block's perspective, we as a company can exist and operate and serve Medicare fee-for-service beneficiaries because of direct contracting and programs like it. We're not the only kind of new entrant per se to come into this space. There are others, our partners and other kind of companies that are competitors who are in the space, and we're glad for it. There's three ways that we think about addressing and focusing on underserved communities. One is, which markets are we launching into? And it is our deliberate focus to launch into markets with underserved populations, both physical, behavioral, and social needs. Thinking about, for the folks who are in the DC area, we're in DC, but we're not in Northwest or Southwest. We're in Southeast and Northeast, east of the Anacostia River. That's where the majority of our population is in the DC market. These are folks who don't have the same access to healthcare, social services. From the types of members we look for, we are looking for members who are medically complex, high utilizers, end up in the hospital, and have been historically disconnected from the healthcare system. That is our sweet spot when we work with insurance companies. Those are the folks we ask about. It's like, hey, who are these folks who aren't being served right now and are disconnected? And we'd love to improve their health and have a chance to improve their experience in the healthcare system. And then thirdly, it is because of the incentive structures offered under direct contracting, can we do this in hopefully a scalable way? One that it doesn't rely on charitable donation and community funding. Those are, we're really appreciative of the programs that have underpinned the social safety net and medical safety net in our communities. But to really scale this, to do more of this, we need to figure out a way to pay for it and do it in a way that more organizations like City Block can enter and grow and serve these communities. And so we're excited that the direct contracting payment structure allows us to serve the kinds of communities we want to, serve the types of members we want to, and deliver the kind of care we want to and that they deserve, and do it in a way that we can repeat and scale across other markets as well.
Emily or Sophia, anything to add on this point, just as you think about access to care in underserved populations?
I think just two quick things which have been touched on already, but just to pull them out in terms of potential risks and just things to be thinking through. I think one, and I think Gary talked about this earlier, is around risk adjustment, right? That we want to make sure that we're not inadvertently risking folks, the most underserved, the most vulnerable people, out of a model, or making it more difficult for them to receive care or to see a care provider that they want or need because of their condition. So the risk adjustment really matters. And then in terms of reaching vulnerable populations. And then the second thing is just around care teams. I think Gary or Kosh mentioned this as well, but just to pull out the care teams that we're building, these models are really, really important, and making sure that we're building payment structures, right, that are going to support a care team with trusted community-based organizations from that community where they have ongoing relationships and trust with the community, with the vulnerable populations that they've been historically serving, is absolutely critical to reaching the most vulnerable populations in our country through these models.
I would just add that I think just a finer point on that, I think really embracing community engagement and involvement and evaluation at the entity level would be really impactful and meaningful. And I think one of the things that, this is maybe an ancillary point, but one of the things that I think is always valuable about ecosystems of care where health systems and health providers are working with other social service providers or community-based organizations is that there's a great opportunity to shine a light on what's missing more broadly in terms of investment in this country around social determinants of health. And so I think, thinking about the ways in which entities like City Block can, share information about what you're learning about what those underinvestments have done to communities over the years, and why it's important that those bigger investments are made is essential. Sometimes I get a little bit worried about when we're in the health space talking about social determinants of health and talking a lot about things like basically referral, tech tools in the provider space to refer people to nutrition assistants or housing assistants, that there's not as much awareness across the board that a lot of times what's really happening is a healthcare provider is having yet another conversation with somebody about how they're still on the waiting list for affordable housing. And there's not really the opportunity leverage to take that data and really shine a bright light on where the real need is and where investments need to be made. It might be interesting to explore the ways in which shared savings could also go to some of these community-based organizations as a part of the evolution of the model.
Great. Okay, at this point, I have one more question for the moderated portion of the briefing, and I did just want to remind people if they have questions from the audience, please use the Q&A or the chat feature, and we will capture your question and save some time at the end. But I wanted to ask, the first cohort's underway. Gary's entity is in the first cohort. Akash's group is following up in 2022. Do we have any indication of what we're expecting in terms of patient outcomes or satisfaction or just early reflections on the program? I think one thing I have noticed is that just because there are so many various options and tracks under the model, I think there are some misconceptions floating around out there. And so I guess I will just open the floor to any panelists that want to address any of the misconceptions or to share sort of what they're, Gary, to the extent that you have any early feedback, or Akash, obviously you have experience in other markets, just in terms of outcomes or satisfaction, or really just patient experience of the model.
So I'm happy to go first. I think it's a little early for talking about outcomes, but one thing I think that is really important, again, the organizations that have come together to participate as part of AIP have been providing care in their communities for a long period of time, but they haven't been able to provide care kind of in a value-based model where they're able to have the data to really see what's happening with the patient on a 360-degree basis. So the data, for instance, that CMS is providing and that our organizations are beginning to really sort of figure out how to use more effectively to improve and augment the kind of care they provide, and to really figure out and anticipate needs, I think that's really beginning to come through, and it's been very exciting to kind of watch that unfold. So it's a little bit of almost a process piece, but I think it augurs well for the model, where providers that are very attached to and concerned about their patient populations and looking at them holistically are now able to see kind of the bigger picture of what's happening, and are able to kind of help marshal some of those resources that are needed to really help the patient, and not focusing strictly on the clinical, and even from a clinical perspective, having a better idea of what's happening from the patient holistically. So I think that's kind of early positive signs. And we're very hopeful for all the different reasons that were pointed out. I think community engagement and building that ecosystem is really vital to the model's success, and something Akash said, which is finding ways to really connect with those who are unconnected to care. We're fully committed to that, and I think that's an effort that would be great to work with CMMI further about, in terms of how to further that goal kind of under the model and other CMMI models as well.
For City Block, we are going to participate in direct contracting starting in January, so don't have direct contracting specific results. But we've been around for the past 4 years serving Medicaid and Medicare Advantage members and duals members. And based on that experience, still early goings, we've been able to see that we are able to improve health outcomes, reducing readmissions by 10 to 20% in our kind of most mature cohorts. And then from a patient experience standpoint, hard to look at quality just yet without more data, but from a patient experience standpoint, we look at an actively measured Net Promoter Score. What do our members, our beneficiaries think of us? Healthcare average is typically in the 20s and 30s, and we're at around 90. And that's something that we actively monitor and are proud of, and want to continue to improve and retain, because at the end of the day, we're here to improve our members' experience in the healthcare system.
So I don't have much to add here, obviously, since I think we're seeing how beneficiaries respond who are currently in the model, and we'll continue to see how they respond for the new entrants that will be starting soon. So nothing specific from me to add about what we're seeing so far from the beneficiary experience, other than sort of the risks and the specific pieces that we'll be keeping an eye on to make sure that access isn't hindered, that patient experience is at least neutral, but hopefully positive is the goal. The one thing that we didn't touch on too much was just about, I think Akash sort of mentioned it here, is about sort of performance metrics, which I think is a really critical piece of this. And just thinking about Akash's comments about patient-reported outcome measures, and I think really taking that next step with models to make sure that we understand from a patient's perspective how their perceived health outcomes may or may not be changing within a particular model. So hopefully that's sort of hopefully the iteration that we're headed in with CMS with some of these newer payment models as well.
Great. Thank you. So we have a question that came in over the Q&A about primary care capitation versus global capitation. Sort of what are the benefits? Why would a DCE pick one, global over primary care capitation, or vice versa? And then what would that mean, just the impact on the beneficiary? What would it mean for the beneficiary? So I don't know, it's fairly technical. Maybe Gary or Akash, you want to take the pros and cons point of this, and then maybe the beneficiary aspect, Sophia or Emily.
Sure. So Akash, you want me to take a whack, or do you want to go?
I can start this one. So primary care capitation, sorry, there's two pieces. There's a professional versus global track, and there's a total cost of care capitation and primary care capitation. So let me talk about both of those pieces. The professional versus global track, that's basically global is higher risk, higher reward, affording participants a chance to get 100% of shared savings or shared losses, whereas the professional track is more of the 50% shared savings, shared losses track. So it's a difference between high risk, high reward. What is your comfort? What are your financial reserves like? What is your historical experience been? So that's the overall, what risk am I taking on how much money might I receive from performance or OCMS? Then on the capitation payment side, that's the more of a cash flow piece. Again, like moving away from the fee-for-service chassis of having to wait for billing claims to get paid. There's a primary care capitation piece where providers who participate can get their primary care component of the services delivered as a monthly payment, as opposed to waiting to file claims. And then there's a total cost of care capitation piece where you get a capitation payment, not just for your primary care services, but to your specialty services, hospital services, post-acute care services, and so on. From CityBlock's perspective, we're focusing on the primary care capitation side. We are mostly primary care docs, and that's where we intervene. I can hypothesize that there are large health systems and integrated delivery networks who are furnishing directly for more of those services, and they may see, hey, more of these specialty acute care services are within our purview, and we're happy to move to capitation on those as well.
Yeah, and the one thing just to come behind Akash, who I agree with everything was just said, on the total care capitation, the non-primary care providers have to agree by contract. And so the way that the total care capitation works is it's based on the contracted, both the participants in the direct contracting entity, and then those that are contracted as preferred providers that would elect to have, for instance, a reduction in the fee-for-service payments. In lieu of those fee-for-service payments, those payments are then made as part of the capitation for the direct contracting entity. And essentially, the direct contracting entity is then ultimately the payer for that preferred provider, and that's really in some ways how the TCC works. And the goal there is to give flexibility to allow organizations to build an ecosystem. But again, it's all voluntary in the sense that there has to be contracts that are put in place really between the DCE and the provider organizations to enable that.
Okay, great. Thanks, Gary. I know we promised to be diligent about sticking to the hour, so we will go ahead and wrap up at this point. I want to thank our panelists for a really robust conversation. If anyone has any further questions for the panelists, please feel free to reach out to me. I will go ahead and share share at the end of this my screen again so that you can see my contact information just in case you again have any questions. So let me go here to the last slide, and we really appreciate everyone's time here today. And again, thank the panelists, but also for the attendees that hung in there with us for the whole hour. So here's my contact information. Please feel free to reach out, and thanks again to everybody for joining.